not as much a question as a comment. So the whole IRB thing, I think, has been a challenge for a lot of us. Back before I took my position at UVA, I actually worked at the State Health Department for 17 years. And in public health, we started to do research, and we asked around, like, who needs to approve this? We didn't even have an IRB at the State Public Health Department, and I put a bullet on my back and started one. And so we now have one at the Virginia Department of Health. But we work with a lot of entities that don't have IRBs, and they rely on us. And I think it creates a problem because, like, there are large entities that don't have IRBs, and they're not funded to pay an IRB to review their studies. So that's one issue. And then the second is just best practices with IRB review for telehealth. Like, it took us probably about 5 years to get our IRB to really understand what virtual care was and kind of that learning curve. And so if this group could really help with, like, best practices in terms of the language that you put in to help kind of educate your IRB to really understand telehealth, I think it would be a great resource.
I agree, and I think the centralized IRB is going to really help us as researchers in conducting telehealth research, and because we can standardize a protocol at the one site. It doesn't have to go through the 5 sites, for tweaking and things. So I think it really will help, and then also standardize protocols that we can use when submitting.
Did smaller sites allow your university? You're at a university. You're at the state.
Now we're at University of Washington.
Would they allow the university's IRB to sort of, give them proxy IRB approval? Yeah, we got caught up in a lot of that. Yeah.
That's not the problem as much as sort of an archaic belief that you have to be in person to consent the patient, and I don't really fully understand that. I don't think it's law-based in any way. It just seems to be the IRBs have this attitude. I mean, don't you agree, Sarah?
Well, I do. I agree with that, but there is a movement towards online consent, so that will really help. So we could technically place an iPad at a remote site, go through with the informed consent process with the patient, and then sign or digitally or online.
You may have an idea of why the hell it's like that.
Well, so yeah, so it's just the same reason it's really hard to get your cardiologist to, see a patient via video, because they think they need to listen to the dude's heart. But reality is, and I've now done this, I cannot find a cardiologist who ever had a clinically stable patient who walked in for a visit that just randomly had a new murmur on that day, right? You don't need to examine these people. There's nothing that's different. It's the IRB. They're just sort of afraid of the unknown. And I'm thinking, as you're asking that, one of the things that we need to do is we need to strategize how to get in front of them rather than at one thing. So somebody that's done that sort of study, and it clearly exists, there's people that have done it, needs to go lecture at whatever the heck the IRB national meeting is about how this worked really well. And then everybody from every IRB hears it at once, rather than each one of us fight with our own IRB to do that. And I think if we came up with, I don't want to call it a lobbying strategy, but a strategy to educate people and find where the pressure points are and find someone who solved the problem and put them in front of the masses that do this, then we could move ahead a lot faster than, well, Kurt, you going to your place and me going to mine.
I'm always advocate for getting research to rural communities. In other words, that's a big deal to say that they're largely left out of research. The rural areas are largely left out of research protocols, and they want more engagement. But this seems to me to be a direct interference with consenting patients in the rural areas, because you can't afford to put a research nurse in every little city to do this work, but you can have a central consenting group that could consent these patients, and then they could be part of the protocol.
Not just a rural issue; it's it's an everything issue, and the NIH in all their studies is really focused on these pragmatic trials, which to me is a code word for a less rigorously designed trial.
It can be underserved in the city as well as in the rural area.
And the reality is you can just have economies of scale if you can do this right, no matter where you are.
that's why I think maybe we should partner with some of the trial networks that are being organized, especially in the rural areas. And hopefully, I'm peripherally involved with one, so I am going to really see how this process works related to the centralized IRB online consent in the rural settings. We've got 17 rural states that we're going to be involved with this process. And but not necessarily with telemedicine. But if they can do it with a drug study, we should be able to do it with telemedicine.
In this case, you're using telemedicine to help in another kind of research, but it is an interference. I mean, if you can't consent people remotely, then you're left with doing it in person. And getting a practitioner or a nurse in somebody's office to be able to do this, they have to go through all this online, IRB training stuff, which they're not going to do. They don't have time to fool with it. So
can I ask, if we were to, and because we're tight on time, if we were to sort of say, let's tackle 2 things, 3 things, I don't know what the number is this one of the biggest pain points? What's on your pieces of paper that Judd asked you to write down? Is virtual consent one of them? Is research pipeline one of them? That was just an innocent plug. I don't know where it came from.
So I want to run around the room, actually, because we're running out of time, and just like one person at the table, don't justify it, say what the pressure point was, and that'll get to Brendan's point. And then I think, maybe at the break or later in the day, I think his idea of, like, if we could as a group be tackling 2 or 3 of these things over the next year and solve a problem and develop a strategy to do it rather than just sit in a room and bitch about it, that'd be really cool. So table number 1. Dan, you're the speaker. Okay, so he comes from Brendan. So biggest barrier is getting a fellowship training. He's maybe one of 2 telehealth fellows in the country right now. I like to say he's clearly the oldest, nothing personal, but.
We discussed IRB approval, collaboration, and teaching.
Okay. Writing.
A demonstration of consistency of standards, telehealth, and regular care.
We had 3, even though some of our colleagues have left the table. We had slow uptake among providers. We had challenges with telecommunications providers and agreements, and identifying telehealth and claims data.
So we had primarily staffing, so the clinicians are not trained to do this. And then we also had, on the remote side, our small clinics are not trained to do this. So it's an issue.
We had on our list understanding what the counterfactual is, what people would do if they weren't using telehealth services, and understanding the biases of who the early adopters are from both patients and providers.
Hi, so we had just defining what telemedicine is used for so that when we actually do research, figure out what the value proposition is so that we can define what the outcomes are, because it's not always clear. And then also sharing data, getting enough of the end like we discussed yesterday to be able to have quality research.
We talked about collaboration being a challenge, especially in these multi-site studies that we all want to get going.
We spoke also about collaboration, data collaboration, multi-site data collaboration, and pulling together resources on a grander scale.
We talked about institutional support as well as standardization of definitions.
We talked about collaboration and training providers and faculty.
I talked with myself, I guess, about I'm a policy analyst by training, not a researcher, so I'm interested in looking at and finding research questions that will move the dial with the Congressional Budget Office and other key policy stakeholders, and as of now, we don't really know what that design looks like, so.
I talked with myself and my imaginary friend. But uniform protocols and metric definitions for uniform report so we can do meta-analyses and things like that.
To add that data quality, I mean, that's, I think, one of the other keys.
Yeah, we mentioned provider engagement, but I think we need to do something with at an administrative level. I think that's an obstruction for everybody, getting administrators to understand how you use telemedicine to deliver, except for maybe at Jefferson, but system of care. How do you buy into this idea of how you're going to use this to drive down costs and provide improving the quality of care? And I think at our level we understand that, but the people above us largely don't get it. They think it's like video conferencing, and that's all it is. So.
Yeah, and so some of these things that strikes me, and obviously I was writing so frantically that I'm not sure I even heard them, but it strikes me that a good quarter or a third of what we just said aren't telehealth problems. They're just like research problems, right? Now, certainly, standard definitions and protocols and whatever across institutions is important in the telehealth space. But the other big things that I heard were that it almost sounds like, I wonder if to jump to the end game here, did we just ask for like a toolkit, which might exist in part, coupled with an engagement strategy for a couple key audiences, providers, primarily in the community, IRBs, administration, right? I mean, it does strike me that what we just said was there's a small group of us that know what we're talking about, and we need to figure out a plan to sort of march that path into the right offices and suites, the policy things, and maybe policymakers is a fourth one there.
Right, and I would add one thing, because a word I heard come from a lot of tables is standardization. And so as somebody that's done clinical research in emergency medicine for most of my life, it's the least standardized environment to do things. But I think it's actually 3 different groups of people I've been on in different diseases to write what we call standardized reporting criteria. And now when you submit a journal article with acute care diagnostics in the cardiovascular realm, you have to sort of reference the document and adhere to the document, or it comes back and says, hey, you didn't report this, and you need to report this. And there's variable compliance with it, but it's something that Surge could get together and take, the NQF domains that are going in the measures and say, you need to be reporting these things so they could be consolidated for meta-analysis and compared across studies. I frankly think, my grant strategy immediately is like, geez, if NQF's going to come out with these things, I should be mapping my grant applications to things somebody thinks is important and doing that. And I think if we get together and publish a document, which wouldn't be that hard if we agreed on it with all our different use cases about what should actually be recorded, realizing it's different in neurostroke than it is in, pediatric networks, we could actually get that baseline stuff together, and that could be a year's long work for us to do. It's taken less than a year in every other group I've been involved with. They're less they are less heterogeneous, but still something to work towards.
So standardization, remote consent or virtual consent, I don't know what we call it, and toolkit and a dissemination plan. If we sort of tackled that over a 2 to 3 year plan, or at least created a path forward for it, does it give anybody bad agita on things that would be missing from what they said? Agita is a technical word. You guys might need to look it up from my Italian grandmother.
That email site, which was
Yeah.
Research. Yeah, you can send. No, the email site. You can send additional kind of ideas or comments, and we can use that as a clearinghouse.
Mm-hmm.
And everybody can have access to it, and we can.
So it's research.
You want to say it one time real quick anybody know it?
researchconnectedhealth@gmail.com.
Okay. All right. Well, thanks, everybody.